Evening. It's my pleasure to welcome you to tonight's presentation on the Fall Respiratory Illness Campaign. For those that may not know me, my name is Gail Romanitz, and I am the CEO of Pharmacists Manitoba. This session is being recorded and will be posted to the Pharmacists Manitoba website for your convenience. We will also provide a hard copy of the presentation. Please look for details of where you can locate these documents in an upcoming issue of the weekly script. After the presentation, you are encouraged to type your questions into the chat feature. Now I'd like to turn the meeting over to Inga Hossack, who will introduce our speakers for tonight. Inga is a manager with the Immunization and Inventory Unit of Communicable Disease Control. Her team will also deliver tonight's land acknowledgement. Thank you for joining us, and I hope you find this presentation helpful as we try to increase access to vaccines for all Manitobans. Inga, the floor is yours.
Thank you very much, Gail. So I wanted to first thank everyone for joining us tonight. I know where I'm in the Interlake, it's a beautiful evening, so I appreciate everybody who's able to participate and hear what we have to say around the respiratory illness immunization program that's going to be starting in the coming weeks. So I'd like to start off with the land acknowledgement. So we acknowledge that we are gathered on Treaty 1 territory and that Manitoba is located on the Treaty Territory's ancestral lands of the Anishinaabe, Anishinaabe Innuak, Dakota Oyate, Dene Sulene, and Niheno-Wook nations. We acknowledge Manitoba is located on the homeland of the Red River Métis. We acknowledge northern Manitoba includes lands that were and are the ancestral lands of the Inuit. We respect the spirit and intent of treaties and treaty making and remain committed to working in partnership with First Nations, Inuit, and Métis people in the spirit of truth, reconciliation, and collaboration. So before we get into it, I just want to introduce the team. As Gail mentioned, I'm Inga Hossack. I'm the manager of the immunization and inventory components within the CDC unit. We have doctors Brent Rusin, who is our Chief Provincial Public Health Officer, and Dr. Devinder Singh, who is a Medical Officer of Health for Vaccines with Manitoba Health Seniors and Long-Term Care, and is also a regional medical officer of health for Southern Health Santé Sud. And we also have Dr. Richard Badak, who is the director of the Communicable Disease Control Unit within Population and Public Health Branch. So just an overview of our agenda today. We'll be doing a respiratory season outlook, registration, ordering, and distribution, looking at supply and products, looking at program goals, clinical information, and in the end, we'll be able to hopefully get to some of the questions that I'm sure that others will have. So with that, I'm going to turn it over to Dr. Devinder Singh, who will go over the respiratory season outlook.
Great, thank you, Inga, and thank you again, everyone, for joining us today. We'll start with what the outlook might be for this upcoming respiratory season. So pre-pandemic, before COVID-19, we would look to the Southern Hemisphere to see what might be coming in the upcoming influenza season, at that time being the main respiratory virus that we would be tracking. And as you all know, they're currently experiencing their respiratory virus season at the moment in the Southern Hemisphere. And at that time, before COVID-19, Australia and Chile were, the two best kind of countries to look to see what might be coming for North America and the US and Canada. So, looking at those countries, they've had an overall kind of average respiratory virus season this year. So there's some variations between each virus compared to last year and this year in each country. But when you put it all together, it looks like roughly an average sort of respiratory virus season in terms of activity. And we'll go to the next slide. So for brevity for this presentation, I'm just presenting some of the information for Australia, but there's links included for Chile as well in the slides when they get distributed. So looking at the first graph, this is more of a syndromic look at people with fever and cough symptoms, so not specific for any virus, and over the different weeks throughout the epidemiologic year. And if we look at the graph that's in, or the line that's in green in that graph, it looks to be tracking with roughly the 5-year average. So, in terms of people experiencing those symptoms, it looks like roughly an average sort of year for the 5-year average, excluding 2020 and 2021 because they were so abnormal. Then the graph that's just below that looks at the COVID-19 activity, and they experienced a shift in when that activity started to rise significantly. But overall, the magnitude of the activity was roughly similar year over year, and we know that there's still not reliable predictability for COVID-19 epidemiology. So everyone's still looking to see what will occur with that virus, each year and each season. Next slide. In terms of influenza cases, they had a similar kind of peak magnitude of cases as from 2022, but wasn't nearly as early as it was 2 years ago. So they experienced roughly the same average timing of the increase in their influenza activity. And then looking at the figure below, that's for RSV. They only have 2 seasons worth of data because it's relatively newer in terms of the spotlight being focused on RSV, and they did experience some increase in case detection there, but still, again, not so out of keeping with what they experienced in 2023. Next slide. In terms of what sort of genetic characteristics there were for the viruses that were circulating. So influenza, it was predominantly an H3N2 year, which means that it would typically be expected to impact older populations more, though all of the high-risk populations would be impacted and were impacted. There was very little oseltamivir resistance that was detected, so less than 1% across all of the different strains, with variability between each strain. And roughly 92 to 100% of the samples that were tested were antigenically similar to the components of the vaccine, but it's too early for the vaccine effectiveness estimates for the Southern Hemisphere, but still promising that at least the samples tested looked relatively similar in terms of the genetics to what was included in the vaccine. And then lastly, for COVID-19, almost all of the samples now are from the JN1 sublineage, and it keeps breaking off into more and more subvariants. And about 3/4 of those were of the KP2 and KP3 kind of specific sublineage of JN1, which is, if that translates to what's experienced in North America, that would be favorable because we are going to receive the new formulation of the COVID-19 vaccines that are based on the KP2 strain. So again, that would be good, hopefully, in terms of a match between the circulating strains and the vaccines. Next slide. And then over to you, Inga, or Dr. Badak.
Thanks, Dr. Singh. Okay, so we wanted to spend a little bit of time going over our registration process and vaccine distribution. So as hopefully everyone will already know, registration is open. It's very easy to register to participate in the influenza and COVID immunization programs. Simply fill out the registration form online at the link on the screen and agree to the program requirements. We will be planning to require registration each year, and the reason for that is primarily just to ensure that we have the most up-to-date information for each location. So we wanted to talk a little bit about how we distribute vaccine. And so we'll be following essentially the same model that we have in the past couple of years, will be using the provincial vaccine warehouse at MDA to store and distribute vaccines to all providers across the province. We'll be splitting providers up into 2 groups, and those will be evenly balanced in size, provider type, and also by geography. So all of the non-priority locations will be split according to their holding point number, with group 1 including holding point numbers ending in 5 through 9, and group 2 including those holding point numbers ending in 0 to 4. Last year, we included all of the priority locations, so hospitals, First Nations, long-term care, within one of the groups. And so they had the opportunity to request vaccine every second survey. And a change that we've made this year is to allow them to actually request and receive deliveries with both groups. So that's just simply reflecting their priority, ensuring that they have every opportunity to request vaccine that they may need. So continuing with some of the discussion of our delivery process, we're going to have some consistent practices. So online order surveys will be emailed to the contacts that are identified during registration. Those surveys will always be open for about 4 to 5 days, and they'll close at the end of day on Tuesdays. Shipping will then start the following week. We'll be beginning the season with a bi-weekly delivery frequency. And then as the program continues and as demand may become reduced later in the season, we may adjust that at that point. As I said before, priority locations will have access to weekly deliveries. So they'll be receiving each of the order surveys, and they'll be able to request vaccine with each delivery. We do get a lot of questions about how we distribute vaccine and when we distribute vaccine. And so we thought it was important to talk a little bit about how we get the vaccine. We get questions sometimes along the lines of, could we get all our vaccine at once? Or it would be really useful to get the vaccine much earlier. And so I think that some people may presume that the province receives all of its vaccine early in the year, and may or may not be making decisions the right way around when to distribute it. So we wanted to, as I said, provide a little bit more background information. So Manitoba participates in the bulk purchasing program that's led by Public Service Procurement Canada. And as part of that process, we receive influenza vaccine through 4 or 5 separate deliveries between about mid-September and the end of October. There are milestones associated with the manufacturer's contracts. Generally, the provinces are supposed to receive 50% of their total vaccine order by September 15th. Unfortunately, typically that doesn't really happen. And so our best information for this year is that by September 15th, we'll be receiving about 34% of our provincial order, with 50% coming a week later, and then gradually over the next few milestones reaching 100% by the end of October. We don't have the option to receive our entire allocation all at once or upfront, and the percentages and dates noted remain tentative and may change. So typically, any given delivery would be confirmed in terms of date and quantity within about 2 weeks of when we'll receive it, 2 weeks or less. So just again, to give a little bit of an idea of what we're working with in terms of when we receive vaccine. Okay, so in terms of COVID-19 vaccine, the Government of Canada continues to procure COVID-19 vaccines for all of the provinces and territories. It's still following some of those original contracts that Canada entered into with manufacturers from the outset of the pandemic. And so it's a little bit of a different process. However, one notable piece is that this year, Canada has determined it will not be procuring any Novavax vaccine. So that won't be available anywhere in Canada. We do anticipate that the products available will be available at the same time as influenza vaccines once they receive approval from Health Canada. All right, and then just to talk a little bit more about the front end of the season in terms of vaccine distribution, we will be asking all participating providers to request sufficient vaccine for 4 weeks supply on their first survey. We're anticipating we should have vaccine in that sort of third week of September, with that first shipment being used initially to fill the orders for priority locations. And again, as I said earlier, priority locations will be shipped with each shipping group. For non-priority locations, it's quite possible that we may split your allocations between 2 separate shipments. So again, if you recall that anticipated delivery schedule, we are anticipating receiving vaccine every week or every 2 weeks for the first several weeks of the season. And so, as an example, just to illustrate this, if a given location is being allocated 1,000 doses of flu vaccine, based on the total demand and the amount of vaccine that we have in stock at that time in the season, we may let the location know that they'll receive, say, their first 400 doses in the first shipping week. So if they're in group 1, week 1 ETA week of September 30th, and the remaining 600 doses of their allocation in the third shipping week. Similarly, group 2 would receive their first portion in week 2, ETA October 7th, and then the rest in week 4. Once again, noting that all shipping dates are approximate at this time and depend on supply of vaccine and timing of deliveries to Manitoba. All right, at this point, I'll turn it over to Inga.
Thanks. Trying to do like multiple screens and unmute and everything like that and move slides. So first we're going to get into product availability. So for influenza vaccines, for the general population, for 6 months and over, we're going to have the Flu-Laval Tetra and the Fluzone Quadrivalent. And so the notable change here this year is that we won't have the Afluria Tetra, and that was a product that was approved for 5 years in age and older. So now we won't have to really worry about juggling that product around to make sure that's kind of being used for the 5 years only, like 5 years plus. So all the product that we're going to have this year is going to be able to be used for the 6 months of age and older. For the 65 years of age and older population, we will have the Fluzone high dose quadrivalent product again. And going to COVID vaccines, there will only be the mRNA vaccines, as Richard had mentioned, and it'll contain the KP2 strain. The only products that will be available this year is Moderna that will be used for 6 months of age and older, and Pfizer 12 years of age and older. So just a notable change there that Canada is not bringing in any of the Pfizer pediatric or the Pfizer infant. So those will not be available. And again, just reiterating, the government of Canada did not procure any Novavax for this coming year. And then just to go into the cold chain requirements, I'm sure everyone is aware, and whenever I go to pharmacies, I see everyone has their vaccine fridges, which is really great to see. So, all flu and COVID vaccines are shipped and delivered to providers in refrigerated state. So COVID-19 should be refrigerated once received. They should not be refrozen. Once in the fridge, the timelines for storage should be followed as per the manufacturer's guidance for pre and post puncture, and that's all in the product monographs. This is, I know everyone probably already knows this, but just reiterating. And then we will have some updated storage and handling for Moderna, which I think will be really good for everybody this year. So Moderna had submitted an application to Health Canada to extend the shelf life for a product once it's removed from the freezer. So it was previously, like last year, it was in the refrigerated time before puncture was 30 days, and now it's going to be 50 days. They did submit for 80 days and they did not get that. So it is going to be a 50-day refrigerated time. So that does help also with, you know, the distribution timelines and everything. So we're hoping that will be good. But also I just put a note there that Pfizer's refrigerated storage time before puncture is going to be the same at 10 weeks, which is 70 days. There will be, same as last year, we will have like a storage and handling chart that will be available on our website that will kind of lay out all the refrigerated time before puncture, room temperature time before puncture, and then like after puncture time. So that will all be updated once we get all the Health Canada approvals and all the product monographs have been released. So as of yet, we have not received any notice that Health Canada has approved any of the flu or COVID vaccines as of yet. So that typically does happen kind of early to mid-September, which is again why our delivery dates are what they are. So the vaccine clinic locator map, so formerly known as the vaccine finder map. So we are implementing a new map this year. It will not contain any information on inventory. The map will advise really as the public, you know, to contact a location that they find on a map to determine supply availability. So when you were registering for the program, every location was asked to provide details that they want on the site. So the website information, if you have any, you know, your actual physical address and phone numbers that the public would call so that we can put that on the map. And if there's anything that if you don't want, you know, to have anything on the map, or you want to change something, or you want to put specific information, there's actually ability for us to kind of be really make it a little bit more unique for a specific location. So we just recommend that you contact us through our vaccines@gov.mb.ca email if you have any questions, or if you want to kind of tweak how it's showing up on your map of kind of certain information. So a big notable change, which I think everyone is going to be happy with, is that providers will no longer have to report their inventory or send us any reports or let us know you know, anything. So it's basically, we just want the public to be aware of what locations had registered with us, and then we're leaving it to the public to be able to kind of determine to contact each location on their own. For resources, so I wanted just to kind of put a plug in that we do have print materials such as fact sheets and posters that will be available to order. So once supply is available to order, we'll send out, create an order form, and that will be available and shared. So the standard, so I think we really want to encourage all providers to make sure they're ordering and displaying government materials. We're going to try, and I think there's a new campaign that they're creating. We just haven't seen it yet. So hopefully that will be available soon and before everything kind of starts, so that we can kind of really start to promote the program as it's kind of being rolled out, instead of it being kind of later, which is unfortunately has happened before. Just to note, our standard dose and COVID-19 fact sheets will be translated into multiple languages. They will just be online, available electronically, so they're able to be printed. But we're looking at 13 languages this year, and we'll see what happens in future years. But we're going to start with 13 languages and go from there. So that will be available online. So this is just a key summary changes just to kind of go over. So all standard dose influenza vaccines, again, will be used for 6 months of age and older. There will only be the Moderna for 6 months of age and older, and Pfizer for 12 years of age and older. Moderna has that extended shelf stability or fridge stability up to 50 days. The vaccine clinic locator map will be updated just to include location information only, and no submission is required for any type of weekly reports or anything. There'll be bi-weekly deliveries to distribution groups, and priority locations are able to receive deliveries weekly if needed. And the first survey may be split into 2 deliveries. So that's all for me. So I'm going to turn it over to Dr. Brent Rusin and to go over the next part for the clinical information.
All right. Yeah. Thanks, Inga. Yeah. And thanks everyone for joining us tonight. And thanks for your many contributions to improving the health of Manitobans. And so really want to talk about a number of our goals and some of the clinical things that we found over time. So, over time, we've had increased uptake of our influenza vaccine. Pre-pandemic, many years there, we look at about 20%, 22%. So last year we hit about 25%. So certainly one of our goals is to improve that uptake, certainly in the high risk population. And then of course, trying to limit those missed opportunities that I'll speak about a bit later. So, so again, when we look at this slide, this is the real issue I see, is that we have usually abundant supply of vaccine, but we're still, vaccinating about less than a quarter of our population with influenza vaccine. And so that's our real goal, is try to improve that. And every year we leave about 30% actually of the vaccine that we bring in on the shelves, never gets into people's arms. So those are the issues that we want to focus on and really try to improve and try to work with all of our partners like yourselves to improve that uptake. So I know that, early on in the season, there's often that real drive to get as much vaccine everywhere as possible. And so you can see that we don't get all our vaccine in at once. And we ship to, about 1,000 unique places. So we just can't get that vaccine to everyone at once. So every year there's no doubt going to be people waiting a bit longer. But it's easy to see, though, at a population level, at a population health level, that's not really the issue, right? The issue is that we need to try to increase that uptake. So as soon as you get it, start vaccinating, but no doubt some people have to be waiting longer, but thankfully that doesn't impact the health of the population. What we're really looking at is increasing the uptake overall with it. So we'll speak about a bit of those missed opportunities. It's really important that at every visit, every encounter, there's an opportunity for vaccination and that recommendation for vaccination, especially a specific recommendation to an individual that may have a high risk condition or high risk age group. So next slide. And so we looked really closely at the ICU admissions last year. And we really saw that this isn't some elusive population that we just can't get in contact with or hard to reach. Most of the people admitted to ICU were, of course, unvaccinated, but most had multiple contacts with the healthcare system. They're on multiple medications, they're receiving medical treatments, they see multiple providers. And so we see those as those missed opportunities, right? They're high risk. It's easy to predict that these people are high risk. And we had multiple encounters with them, and we didn't get them vaccinated, right? So that's that missed opportunity. Now, obviously, we don't know. They may have been offered a vaccine at every possible visit, and they're just a bit hesitant. But we still want to limit those missed opportunities. So when we see those cardiovascular disease, those over age 65, diabetes, and in that younger group, 6 months to 4 years old, these are the higher risk individuals, and we see predictably those unvaccinated and those with multiple contacts to the system, we still didn't get needles in their arms. So we're going to keep doing whatever we can to get that messaging out, support our providers, but we want to reach those at high risk to really decrease that risk for the individual. But also we know that every year we see that strain on healthcare system, surgeries being canceled, people even who aren't affected by the respiratory virus season, their health is being affected because of that strain on the healthcare system. Next slide. And so again, COVID and flu, 6 months of age and older. And we do want to get that shot in some individuals, once they see ICUs filling up or seeing a lot of spread and a lot of adverse outcomes, then they're approaching providers for vaccine. We want to get it to them before that, because we know it takes some time to get that immunity up. So as soon as we start getting those vaccines out there, we want them distributed, and those recommendations coming earlier. We have the conjugate pneumococcal vaccine now, the pneumo 20 vaccine, 65 plus. Are all eligible for that. And we saw, the conjugate vaccine, the pneumo 23, was the best we had, but it just wasn't the greatest vaccine at preventing severe outcomes. Pneumo 20, the conjugate vaccine, is excellent. And so let's take advantage of that. We know the significant impact of pneumococcal disease, especially in those high-risk communities. So this is just yet another protection we have for those high-risk communities, and then we're looking at ensuring that that's going to be available to you to provide as well. Next. And so again, what are their targets? So 65 years of age and older. Infants 6 months to 4 years. In this group here, last year, this was actually the only group, I believe, that actually had decreased uptake from years previous. And for some reason, we saw a decrease in uptake in that higher risk group. So we really want to do whatever we can to ensure we're vaccinating that high risk group. Pregnant individuals, certainly at higher risk of respiratory virus illnesses. And then we can also offer them the Tdap as well. We know the underlying determinants affect Indigenous Manitobans, and they are at increased risk from these respiratory illnesses as well. And in those underlying medical conditions, right, the cardiovascular disease, renal disease, diabetes, and again, this is what we saw in the ICU. It's very predictable, very unfortunate, and and hopefully preventable as we move forward. Next. And so some of the steps that we can take with our pharmacy colleagues here is we want to reach that high risk group of those children under 5. And so we know pharmacists are able to immunize down to age 20, and we know that's that access, right? So individuals, sometimes we may have that one opportunity to vaccinate them. And if we have that high-risk person in front of us, let's offer them that vaccine. So that would be, one added access point for those children down to age 2. Really keeping out for those specific recommendations. We know that pharmacists are a trusted healthcare professional to Manitobans, and advice from pharmacists are taken quite seriously. And so specific advice is even more important. So when you have that client that's on an ACE inhibitor or anti-diabetic medication, right, that specific advice to them, the cardiovascular disease, diabetes, these are all high-risk conditions. You're really strongly suggesting that vaccine for influenza and COVID. Those over 65, we have the high-dose flu vaccine. It's much more effective in that age group, and we're actually seeing really good uptake of that. So continue to promote that in those ages 65. And then with scheduling, feel free to email us, and we'll help promote that on our locator map. We want to ensure that there's a lot of access to Manitobans. There's no barriers to receiving the vaccine as much as possible there. So again, thanks for all of your work and helping us keep Manitobans safe in all your daily work there. And this campaign, we really want to focus on reaching more than that 25% that we do, and limiting those missed opportunities. Those people that we know constitute those populations that have high risk outcomes. Let's do whatever we can to get needles in their arms. So I think that might be it for me. Yes.
Thanks, Brent. So I think unless there's any questions, Gail, I will be, I'm not sure if there's, I only see one question right now, but we'll kind of let it open up if there's other questions.
Sure, thank you so much. First of all, a thank you to all the presenters for your kind words. Dr. Rusin, very, very much appreciated, and for all of your insights. We truly appreciate the time and effort you have put together in putting forth this presentation tonight and helping us navigate the complexities of the Fall Respiratory Illness Program. So I invite members who are on the line and joining us tonight to type your questions into the chat. And I'll try my best to direct the questions accordingly, Inga, but if I misstep in any way, I invite you to direct it to the most appropriate person on your team to respond. So the first question, when will Manitoba be covering RSV vaccines for older adults? And Inga, perhaps yourself?
I'll pass that on to
Richard.
Yeah.
Yeah, so certainly we're aware of the NACI recommendations and so on. I think what we could say is that it's something that's actively under consideration. If and when there's something, some news to provide on that front, certainly we'll be doing that.
Thank you, Richard. The next question, when will I be able to get my FIMS login reinstated?
I think that one is, you'll have to contact the FIMS, like the service desk, the shared health service desk. I will attempt to find that email and put it in the into the chat here. But I think that's the best way. We don't actually have any control over the FIMS part of it, so it's best to connect with them on the whole FIMS access. There is a question there before that one also around the COVID tests, and I will also leave one to Richard.
Yes, thank you. Richard, the next question is, are COVID test kits still available through Manitoba Health? And if so, where?
Yeah, we continue to have some of those in stock. Ordering processes, I don't believe, have changed. We do have, you can check out our website. I haven't got the link offhand, but for information on how to do that, if you haven't before, or if you have before, you can follow a similar process.
Thank you. Karen asked for a recap of the distribution process, and rather than do that, Karen, we will be distributing a hard copy of this presentation. So unless you had a specific question, I think I'm going to move forward. A question from Kim Thiessen. If a patient has had Pneumovax P23 at age 65, are they eligible for the Prevnar 20 after 5 years, or just one dose at age 65 regardless of vaccine?
I will leave that one for Devinder.
Sure. So it would depend on the, whether or not that individual over the age of 65 had any medical conditions that put them at the highest risk for severe disease from pneumococcal disease or for invasive pneumococcal disease. So some of those conditions could be nephrotic syndrome or hepatic cirrhosis. So depending on if the individual had any of those highest risk conditions, if so, then yes, that person would be eligible to receive the new 20-valent conjugate pneumococcal vaccine 5 years after the previous dose of Pneumovax. However, at this time, if someone over the age of 65 doesn't have those highest risk conditions, then if they've already had Pneumovax, then they would not be eligible to receive the 20-valent conjugate vaccine. However, that is also something that's being actively looked at for potential alterations going forward.
Thank you, Dr. Singh. Next question, will Paxlovid be covered under PC? So I'm assuming that's pharmacare. Richard, is that something you want to tackle?
So it's not our area that does that. I don't want to misspeak. So I'm actually wondering, Brent, if you're still on. I can't see everybody. Whether you're able to answer that.
Yeah, so not any details on where that's going to land. Right now, for the most part, Paxlovid is quite an expensive prescription, as you know, and effectiveness is limited, and for the most part, it's people at extremely high risk that should be being prescribed Paxlovid or being considered for it. So I'm not aware, though, of the plans for what coverage will be available for that at this point.
Thank you, Dr. Rusin. The next question, and I'm not quite sure on the intent, but I'm assuming that this question relates to the necessary regulatory enablers for pharmacies to participate in the public program. But the question is, what are the latest updates on the pneumococcal vaccine in Manitoba? And Richard, I'm not sure if you want to tackle that, please. If there's any updates as to timing, or are we still on track to see that change perhaps in time for the fall flu campaign?
Right. So I think there's a couple of different pieces to this potentially. So one is just the vaccines that are being offered. And I think Inga provided the link to the eligibility and you can scroll down and see eligibility for both Pneumo 20 and Pneumo 15. But then with respect to pharmacists being able to administer Pneumo 20, as you said, that is in process. There is a change that needs to be made to the regulations. And I think we had noted it on one of the slides. We're anticipating about an end of September timeline. That's our best estimate on that at this time. So hopefully that covered any aspects of that question.
Yeah, and to the member that asked the question, as soon as Pharmacists Manitoba hears anything in that regard, we will absolutely communicate that message out to our members. The next question is, when will the hard copy of the presentation be available, and where will it be found accessible? We will work with the staff and provide details hopefully this Friday in the weekly script. So stay tuned as we work out some of those details, but our intent is best efforts to have this available by this Friday. The next question is, Prevnar 20 now covered? I think the simple answer to that is yes.
Yes, and I put the eligibility link to the eligibility criteria in the comments.
Okay. Sorry, I gotta just try and advance the chat here. Next question. Now that Manitoba offers new C20 vaccine, which should the pharmacies do with the existing tariffs for pneumococcal conjugate 13, new C13, and pneumococcal polysaccharide, new P23?
I'm not quite sure around what it means about the tariffs, because I thought tariffs are only done with physicians. So I wasn't not quite sure what that means, but I believe the direction that we had provided to everyone when we switched over, because we don't use Pneumo C13 or the 23 anymore, was to no longer use that. I mean, pharmacy shouldn't have those products anyway. Well, they could have the Pneumo 23, but it was to return the product. So, and then we're transitioning over to the Pneumo 20, but Devinder, go ahead.
I just wanted to also add that just below Inga's comment, I also added the link to the healthcare provider letter that was sent out, just on the most recent update for these pneumococcal changes, so from June 27th. So that had the link that goes over the process for returning vaccines, so indicated about returning that 13-valent conjugate vaccine and 23-valent polysaccharide vaccines, because we're again no longer recommending that those vaccines be used because we have the updated formulations of the 15 and 20-valent conjugate vaccines. And then also has hopefully what you all think is a useful table, just breaking down individuals based on age and risk factors and what they may have previously received, and then what the recommendation would be for future pneumococcal vaccination, at least at this time, subject to any future changes from NACI. So yeah, that link is just below Inga's comment in the chat. Thanks.
Thank you. And to the member that asked that question, if that didn't answer, what you wanted to ask, then please continue to use the chat and we can circle back. Here's a comment from a member just confirming that Paxlovid is in fact available and covered, and the location that that individual works at dispenses multiple prescriptions daily. So just sharing that as information. Sorry, just bear with me as I advance through the chat. All right, what is the anticipated turnaround time for ordering new C20 following the amendment to the pharmaceutical regulations? And the next portion of the question is, if regulations are updated by the end of September, is it anticipated these could be ordered and delivered as part of the initial shipments? So I'm not sure if, Richard, you want to tackle the distribution piece?
I can start, and then I'll see whether Inga might correct me on a piece of it. But so it's a bit tricky to speculate on exactly how that's going to roll out. But if it's end of September, we're the first order survey is going to go out before that, and so it's unlikely to be ordered through that process. However, it's also possible to order the pneumococcal vaccines outside of the order surveys. So using the regular vaccine order form would be another way to order that without waiting for the next available survey. And then I'll give Inga an opportunity to correct any of that if I've
No,
got it
that's
wrong.
good. That's good. But yeah, so once it is for sure, I would suspect we are going to have the pneumococcal vaccine on the surveys, but until the regulation is finalized, we won't be able to send it to pharmacies, but it will be on the surveys. And then, but as Richard said, if it's kind of between the surveys, which will be coming every 2 weeks, it is available through our regular vaccine order form as well. So there really isn't much around for turnaround time, because we actually have, we already are shipping it out to physicians and whatnot, so, and public health. So we do have it already. So it's just ready. We're basically ready to go once that regulation change is put into place.
Thank you. A member has a comment confirming that the Manitoba Health website still says Paxlovid is covered by the province. No out-of-patient costs for patient. Special instructions for pharmacies to submit to Manitoba Health for payment are available. And I can confirm on the MIB website, there is a claims procedure set up for Paxlovid. So I would direct you there for further details. All right, bear with me. There's a very long question here. The current situation with pneumococcal vaccines underscores a gap in pharmacist scope in administering vaccinations in Manitoba. Is the province reviewing the legislation surrounding pharmacists providing immunizations beyond the routine immunization schedule and Schedule 2 of the pharmaceutical regulations? For example, some vaccines are classified as NAPRA Schedule 2, yet pharmacists in Manitoba are not authorized to administer these vaccines without a prescription from a physician or nurse practitioner, even when the patient meets NACI recommendations. The current regulatory framework could be reviewed at restrictive, limiting pharmacists from fully utilizing our demonstrated capabilities. So, CPHM is not here to respond, but I think we all are aware of the consultation piece that had an expiration date of August 15th. I can confirm that Pharmacists Manitoba did contribute to that feedback. And I don't know, Richard, perhaps, if you have anything further to comment on the regulatory piece and where you feel government may be headed, subject to, of course, feedback collected from the members as part of that consultative process.
I think what I can say again is that we're certainly well aware of that issue, and it's something that over time we've reviewed more than once, and it's certainly in our plans to have additional review and discussion about that. At this point in time, it's not something where I could sort of provide any direction on where it's going to end up heading. It's a little premature for that, I would say.
Thank you. Next question, for new C20, will there be patient information, handouts, and healthcare info on eligibility available on the Manitoba Health website?
So right after that, I did post a link. We have a disease pages. So on the pneumococcal disease page, it actually has, like for the public, it has the fact sheets there for both. We have the links to the product monographs. And we also have information for the healthcare providers with regards to the letters that we had sent. And there's an FAQ. And then it does go into just like symptoms of the disease and whatnot. But and then there's the eligibility page, as I previously had posted, that has the eligibility for the vaccines.
Thank you. Next question, will the links being discussed be available as part of the presentation availability? As I am not seeing the links. You'll have to give us a couple of days, but we will provide links, but they will not be provided tonight. So just hang tight. That information will be coming and circulated as part of a future weekly script. Next question. Is there any consideration related to pharmacist mobility between practice sites and site-specific functionality within FIMS? For instance, if a pharmacist is assigned to work at a new practice site with less than 2 weeks' notice, it has previously been impossible to register them as an immunizer at that site in time. This creates a situation where a qualified immunizer may be present at a vaccination site with vaccines on hand, but is unable to immunize eligible patients due to administrative red tape. And I don't know who's in a position to comment on behalf of FIMS, or if you can provide any advice, and I can follow up outside of this presentation.
So I'll say that I don't have sufficient knowledge of the reasons for why that's set up that way to give a meaningful answer. I can say that we could bring it back for discussion, but it's also possible that Inga might have something a little bit more than I do, so I'll give her that opportunity.
Yeah, and I don't know for sure 100% because again, we aren't the kind of like FIMS experts for sure, but I believe it has to do with the information sharing agreements and that they are specific to a specific, like you as a person as pharmacists are connected to a certain pharmacy. So if you're going to a different location, then that they have to make sure that you are part of kind of an information sharing agreement. But I'm not 100% sure on that. Again, that would be something, and maybe Devinder even has more than I do, but I'm definitely not a FIMS expert by as well. So again, maybe that's going to that shared, the email that I had shared earlier with the service desk might be the best way to get those answers. Go ahead, Devinder.
The only potential additional advice I could, think of in that circumstance would be, if the, crux of what is felt to be the inability to administer the vaccine is related to the documentation aspect, then, it could be recorded in like hard copy form. Like we have the forms that have all the information in terms of submitting the vaccine information to be added to someone's medical record for e-chart and FIMS. So, I hope that this doesn't occur very often, and it, having to write things down on a form generally speaking, is more onerous depending on the system than being able to enter it directly into FIMS. But if it was possible for you in that circumstance to potentially just write down all the relevant information on that form so that you could either enter it into FIMS yourself later or fax it to public health to be entered, then that's kind of what I would think may work. So again, could not check the patient record. So couldn't access their immunization record. Is that kind of the issue, like not being able to access eChart? So to be able to tell. So, in exceptional circumstances for the seasonal immunizations, like let's say COVID and flu, like if it's depending on the circumstance, if there's something that comes up where you're not able to check that person's record that season, I recognize that it's best practice to obviously check that individual's record to ensure that the minimum intervals are there, just to make sure someone isn't forgetting a dose that they've received. But for most people, for flu vaccine, for example, a lot of them would know if they've had an immunization that year. And for COVID, the minimum interval is 3 months. So again, depending on the circumstance, it's best practice to check their immunization record, but you may be able to immunize someone for a seasonal vaccine like COVID and flu. If you're not able to check that person's immunization record, in these types of circumstances, relying on them to give an accurate history.
Thank you.
Yeah, I recognize that that's best practice is to check the immunization record, but I feel like you're providing exceptional circumstance or where the overriding health of the patient is to immunize that person at that opportunity, and that in this specific circumstance that trying to maximize that person's health overrides the inability to access that person's immunization record in this circumstance. Again, that's not the advice for generally for all encounters. That I would hope that people are able to access individuals' immunization records to confirm that you're giving the correct immunizations for that individual based on their history. But in this circumstance, we're talking about maximizing the health of individuals that you're seeing, and we're talking about trying to minimize missed opportunities. And so I think in this circumstance, it's very defensible to indicate that you're doing everything you can to be able to follow best practice, but in this type of circumstance, that the best thing to do for that person is to immunize them.
Thank you. The next question, is this learning session accredited? And no, it is not. And this was noticed or noted in the webinar invite. And, it's something that, we can try and rectify for next year, but given time constraints, there was no opportunity to have this accredited. So apologies in advance. The next is a comment and just a thank you for simplifying the process this year and not requiring an inventory reporting. So thanks to all of you for making that change. Some further commentary. If no one else has FIMS access at a site, it is a standstill. This has happened to me more than several times. So just some commentary for consideration. If a pharmacy is giving a large number of vaccinations at independent living centers, are we able to make a request for these vaccine, or I'm assuming for that vaccine, on the order link? Planning is a little more difficult for these if we do not know the ship dates. So maybe you can speak to how vaccine is allocated. Is it based on history, or if a pharmacy has an opportunity to do a new event, and Kim, perhaps you can correct me if maybe that's where you're headed with this question, but is there any opportunity to revisit allocation if a pharmacy comes across a new opportunity in light of the 30% wastage?
I'm going to suggest the way I'm understanding this question is that they're wondering whether they can make the note in advance when they're placing the order that a portion of this vaccine is to go into the independent living center, and that since they would have plans to do that on certain dates, to have some confidence in having the vaccine in that time frame. So things like that are things that we try to accommodate. I'm actually going to look towards Inga to see whether I'm uncertain of specifically the method that the member has identified. So whether it's possible to do it in the survey, and I'm wondering, Inga, if you're able to answer that.
Yeah, typically I don't think we've done, that's something we could definitely take back and I think maybe look at, Richard, is whether we do put a kind of notes section or something in the order survey to allow for that, kind of specific, noting any kind of specific clinics or high risk, going into high risk settings to do immunizations, which might be something we can look at. But previously, I think the providers would just email us to let us know that when we kind of sent out our email saying that we were allocating certain doses, and then we would be kind of contacted to advise that they were a clinic was already set up. But I would say also, this is kind of the same messaging that we've provided to public health, was try and plan those clinics. Now that we've kind of given you some ideas based on like those in early slides around ETAs of when, for the first order, and then it might only be half of that first order, right? And then the week 3 would be kind of the rest of it. For if you're in the group 2, don't be planning for clinics or going into places in the second week, or or in that first week, because you're not going to get those doses. So that's why we wanted to try and have some give this information as soon as possible as well, so that we can allow for the planning to happen in a more reasonable fashion, whereas you're not going in the first week of October into these centers when we likely won't have enough doses to give everybody. So yes, they're important to be giving, but like try and plan those for kind of more around, if you're in group 1 or group 2, kind of maybe look at those calendars and see kind of when maybe planning for kind of that 3rd or 4th week of October kind of thing for those clinics. Try to just kind of try and look at that. But again, we totally get that everyone wants to immunize as soon as possible, but now that everyone we've been able to present that we don't have all the doses to give, then hopefully we can try and get the providers to kind of stagger and move around those dates a bit to try and be make sure that they plan accordingly for those doses. But definitely, I think we can see how we can communicate if you are going into a specific clinic or a specific area that is higher risk, such as these independent living centers, that may be a place to put either that in the order, or we'll direct that if you are doing that to email us. So we'll communicate that out when it starts.
Thank you. And then we've got a bit more commentary with respect to FIMS, and we don't have the right people on the call today to address this, but just for awareness, the comment is that the Manitoba Health Agreement requires each patient's FIMS record to be checked, or potentially the agreement may be terminated. So, back to the pharmacist exercising their best judgment in that situation, and hearing Devinder's thoughts in that regard, and also sharing his information that most pharmacies do not have access to eChart. So if you can't go to FIMS, you're really hooped in terms of trying to validate the patient record. And just for the information of our members, CPHM, CSHP, and Pharmacists Manitoba have jointly written to the Minister of Health advocating for eChart access in pharmacies. So, hopefully that will be something that can be reviewed and potentially a solution to the FIMS issue. So I think that is the end of the questions. So I'm going to just keep my eyes on the chat in case something last minute pops up. But while we wait for any last minute questions, I just wanted to, again, thank you for the presenters for your time and your effort in sharing this information with us. Really appreciate your valuable insights and for taking the time to speak to our pharmacists today. And to our members, as mentioned, please watch for details in the weekly script on how you can access the recording and a copy of the presentation. And with that, that concludes this evening's presentation. Thank you so much and have a great evening.
Thanks, everyone.
Thanks very much.
Thank
Bye
you,
now.
everyone.
Thank you.